Welcome to AETCM, the emergency medicine channel. Today we are presenting a scenario. A 26-year-old male came to presented to ER with alleged history of with complaints of inability to close the mouth after a yawning. So patient came walking to ER, so we triaged as green.
Okay.
And then primary survey was on initial second assessment, vitals were stable. The patient was not able to close the mouth.
Okay.
And there was some little bit drooling was also there. He was complaining of pain over the preauricular area. So coming to the examination, local examination, he was having, history is like he was having a yawning, and followed that he is not able to close the mouth. He had similar episode 2 years back once, and then it was reduced. So on examination, the patient attitude was opened mouth without closing, and there is a hollowing in the preauricular area.
Okay.
And
just one question: it was whether it was bilateral or it was unilateral?
It is bilateral.
It was. So how will you differentiate from examination whether it is unilateral or bilateral TM joint dislocation?
On an inspection, there will be deviation of angle of mouth to the opposite side.
To the unaffected side.
Unaffected side.
So suppose the patient is having a TM joint dislocation here, the angle of mouth will be deviated to this side. So he is unable to close on this side. So that will be the classical finding. And another inspectory findings, what all things you will be able to see?
There will be a hollowing of the preauricular area, the dislocation.
Okay.
The joint will be dislocated from the eminence.
Okay. And
anteriorly.
Periauricular, you might be able to see a small depression. And also below the maxilla,
there will be that
you might be the coronoid process, you might be able to palpate. So that is the classical example. So you need to differentiate whether it's a bilateral TM joint dislocation or it's an unilateral TM joint dislocation. What are the common causes that?
Common causes, most commonly it is anterior dislocation. It is mainly by yawning, vigorous opening of the mouth, or prolonged dental procedures. Any anesthesia will be given, and then trauma can be caused.
So the classical history, they will be having an wide opening due to yawning. That will be the classical history that you will get, and they are unable to close it. So they will come with open, and there will be some difficulty in speaking because they are unable to articulate properly because of this dislocation. Then the next, they can also have sometimes recurrent dislocation, connective tissue disorders. And trauma, it is totally different. You need to look in for other fractures also. You can have maxillary fracture, mandibular fractures, and all those things. A trauma can occur. And definitely, when it is trauma related, you should do a proper examination, including imaging, and most importantly clinical examination, the key area, the cheek over the face, because the infraorbital nerve can get affected, then this area, the ventral nerve, can get affected. So proper examination of all the branches of the mandibular and the maxillary nerve examination, especially maxillary nerve examination, needed to be done, including the sensation. And motor function you might be able to difficult, and you will have classical trismus sort of a thing. So what are the other differential diagnoses for this? For a TM joint dislocation?
Any tetany, then
the patient can have a large peritonsillar abscess, which is because of the pain they are unable to close the mouth. So that might be one of the differential diagnoses, but the classical TM joint dislocation is this is what. Now my question will be, do you need an X-ray of a panoramic view X-ray of a mandibular joint for this?
Usually not indicated.
There are traumatic, definitely yes. Not maybe X-ray, you might need a CT also. But when you have a classical history, it is not needed. Like you are having recurrent dislocation. Maybe first time dislocation, there is some history of trauma, definitely X-ray is warranted. Otherwise, it is not required. So that is the initial presentation. Now you have to, how will you manage the case? Can you tell?
The pain management is the key. Initially, we have to give a good analgesic, and if at all required, if it is very much, the metaspasm is there, if you are not able to reduce that, we can give a procedural sedation.
Ideally, you do all the procedure with procedural sedation. The classical thing, benzodiazepine, fentanyl, or any of the drug that you wanted to use, you can use in here. But make sure that you can't have a compromised airway here. Because in other situation, if you are having a sudden compromised airway, you can go ahead and intubate. But here, you will not be able to do that. You might be able to do that with difficulty, maybe a blind nasal intubation, or maybe a fiber-optic guided intubation, or maybe a surgical airway. But this can be challenging, but definitely muscle relaxation will help you in the success rate of the procedure. Suppose you are doing, the patient will be quite anxious, and you need to do a procedure inside her mouth by keeping your hands inside her mouth. So that procedure they might not tolerate. But it's always to give some mild anxiolytics and muscle relaxants prior to going ahead for the procedure. Now you can tell what are the different methods by which you can do the reduction maneuvers.
First method is a Hippocrates method.
Okay.
For this we need a glove.
Okay.
And,
ideally I will say you have to wear 2 gloves. It's very important because all these gloves can get toned when you are putting inside the mouth. You are going to hold it inside the patient's mouth and the teeth can get jammed in between. Maybe double gloves, or you can wrap it around with your help of your gauze, little bit thicken, otherwise the bite can happen over your finger. So in order to protect that, you need to do this way. Then imagine this is the dislocated TM joint. The patient is unable to close his mouth.
So Hippocrates method is we have to put the thumb inside the occluding surface of the lower jaw,
okay,
and then give a downward pressure. The fingers should be at the chin. Give a downward pressure and then a posterior pressure.
Downward,
posterior
upward pressure you have to give. You are trying to put it back in its position. You are dipping it down so that the condyle water being stuck, it is coming out and it is going down. Then you are pushing it backwards and upwards, downwards and upwards, so that it is getting back to in position. It's very easy to say, but it's a cumbersome procedure. It needs some amount of energy. Without that, it is not going to help. So the most important thing, what all the materials that is required: a gloves and a gauze. Then
if in secretion system we can give get a suction and then Magnus forceps if at all the gauze is entrapped in it.
Because suddenly after the reduction, the gauze can get entrapped or the gauze can go inside the oral cavity. So you need to remove it. So that time you definitely need a Magnus forceps to remove that. So these are the just simple things that you require, and a anger suction to suck it out whatever the things are coming out. So that is one method. That is the Hippocratic method.
There is a modification of this in Latent's method. That is, will be keeping our fingers not in the occluding surface, in the anterior border of the ramus inside the mouth, so that we can protect our hands. And another same position with the change is when the patient is in supine. So we have to come at the head end of the patient and then we'll have to stand in the head end, and the same procedure, that is the thumb inside the occluding surface and fingers over the chin. The same process, the caudal one pressure should be given, and then upwards and backwards.
So whichever way you are trying to push the things downwards and you are trying to get it back to the position. So that is one thing. Another method
is pivot method. In pivot method, we will be keeping our thumb outside and all the fingers out inside the mouth, and 3 fingers. And thumb should be secured at the chin, and with the fingers push down the chin, push down the mouth, and with the thumb keep a
close it. Try to close it. Upward pressure. Another one externally. Externally also you can try without putting mouth inside the mouth also. You are seeing the occluder surface. On both the sets you can just start giving a downward pressure, and you can give some massage so that it will come back to position. But that is a little bit difficult, not routinely practiced. The common one that they do is Hippocratic method, and the other modification.
And then it's a syringe method. It is 5 to 10 cc syringe that we have to measure whether it is fit in between the mouth.
So and for this fellow 5 cc is okay. For another big fellow like this, you need maybe a 10 cc syringe.
Then tell this patient to hold with the teeth and then move upward and backward like this. Roll in between.
Roll the syringe in between and bite the syringe and roll the syringe. So that by this rocking movement, slowly by doing this rocking movement, the dislocation will get corrected. So that is one of the syringe method which can be tried without much issue. You can ideally you can try a syringe method first, then go ahead with the Hippocratic method. And another thing while you are doing in the Hippocratic method, this one you need to give a continuous pressure and maybe a little bit of rocking movement you need to give. With that rocking movement, the dislocation won't get reduced. Rather than doing this way downwards, upwards, and it will not get reduced. So instead of that, you give that pressure, and then you start giving us a little bit of rocking movements, and then you push it downwards and upwards, it will get reduced. So that is the one major thing that you need to keep in your mind. And discharge advice?
Discharge advice, either we can give a bandage of
that we are not routinely doing these days. It's actually not indicated. If you want that they are very scared that they want to do a travel and they are you can give a coconut sort of a bandage so that they will not open it immediately. But that is not really indicated. Another thing.
Avoid excessive mouth opening during yawning. Just support the jaw, or laughing, eating while soft diet, and any NSAIDs.
Analgesics needed to be given. So it's a simple, but it's a common thing that can come in of any of the emergency department, a TM joint dislocation, which can be easily managed. But whenever you are suspecting a fracture, when you will suspect a fracture following a trauma, or when you are doing any examination, you are seeing that probably the cheek, there is some sensory supply, there is an issue, you have to think in terms of an entrapment. So that time you might need a CT prior to doing this reduction. Okay, anything else that you want to add on? Okay, that's in a nutshell regarding TM joint dislocation.
Today, temporomandibular joint dislocation reduction methods. First one is the classical Hippocrates method. For this, we will need a glove with gauze to protect our hands. And then the first method is Hippocrates method. It is like we will place a thumb in the occluding surface of the lower jaw and give a downward pressure, and then a rocking movement, and then give a posterior pressure and then upward pressure to keep the joint in the correct position. And another method is the Nilaton method. That is, we'll place our thumb not in the occluding surface but in the anterior margin of the ramus, and then do the same. And then the next method is the pivot method. In pivot method, we will keep our fingers within the occluding surface and then thumb over the chin, and with the fingers we have to give a downward pressure, and with the chin we have to give the upward pressure, just to like closing the mouth. And the another method is the syringe method, that is with for 5 cc syringe or 10 cc syringe according to the mouth opening, and then ask the patient to grab with the both lips and teeth, and then ask him to roll the syringe over the with the jaw within forward and backward movements, and then it can keep it back reduction.